Good morning. I'm Dr. Jose Wiley, and welcome to peripheраlinterventions.org, our live webcast from Mount Sinai Medical Center in joint venture with the American College of Cardiology. Today's November 27, 8:10 a.m. in a very, very rainy New York. Without further delay, we're going to go to room 6, talk to Dr. Prakash Krishnan. Good morning.
Good morning, Dr. Wiley. How are you? And I'd like to welcome everybody to New York City. As you know, we've had an exciting partnership here with the American College of Cardiology and have been broadcasting cases since July. So we're almost at our, this is our fifth case, and we're ready to roll. I just want to give you a little update on last month's case. Because the last 2 months we've had cases where we've actually had difficulty finishing the cases within an hour, and as those of you know, with peripheral interventions, sometimes that can occur. So clearly here we're going to try to get this case done in an hour, but before we present the case, I want to introduce our team in the lab. We have Marichu, our nurse. We have Ricardo, our tech. We have Karthik Guja. Dr. Guja is our endovascular structural fellow here at Mount Sinai, the first one, and we have Surabhi, who's our interventional fellow. Without further ado, I'm gonna have Karthik present the case that we're gonna present, and then we're gonna finish up. Actually, you know what? Let me go outside, and we're gonna finish up last month's case first. So 1 second. Yep. Okay. So now, can you hear me, Jose?
I can.
Okay, great. So I just want to show you last month's case, and for those of you who remember, we were at a process of where we could not cross the posterior tibial. We got a wire across, and we could not get across with anything else other than a wire. So what we did at that stage is we decided to go and get tibial access, which I'm going to show you right here. So we decided to go get tibial access. And give me a second, let me find it. So
Prakash, you tried an antegrade approach and it didn't go, and then you decided to get
retrograde. So what we did was we had an antegrade approach. The wire was down, as you can see here. However, we could not cross anything. We could not cross our crossing catheter across the lesion because of calcification. So at this stage, we went ahead and under fluoroscopic guidance, got tibial access in this critical limb ischemia case. Once we got tibial access, we went ahead, advanced our wire up, and you could see we advanced our wire up. I'm just going to skip ahead. We advanced our wire up across the lesion, you can see here, and the wire we used was a very, very stiff wire, coronary crossing wire, which all of you are very familiar with. And really, literally, you can use any 014 or 018 wire in order to be able to cross. Once we crossed, we used a support catheter to try to track across, and you can see here, this is nothing but an 018 support catheter, and this would not cross. And finally, we used a coronary transcollateral crossing catheter to be able to push this across the lesion. Once we pushed it across the lesion, we snared the wire from above, essentially creating a really stiff rail. And this technique has been described before as the Safari technique, which we wrote up in the ACC journal, but which you're going to be able to see when it's published in the next couple of months. So once we snared it from the up and over technique, we were able to then go ahead, and they could see the snare being pulled through our sheath, and you can see here the wire coming back. And then here you can see us externalize the wire here. Once we externalized the wire, we were then able to track our crossing catheter across up into the popliteal artery because of the rail. Then we did balloon angioplasty, and then we did atherectomy, and I'm going to show you the final result. Here you can see in a second. Let me just skip ahead, and for the sake of time, and just show you our final result here. So you can see here, this is the final result. And you could say, well, it's not perfect. Well, we were able to avoid stenting. We were able to get straight line flow into the foot, and we were able to open the posterior tibial artery.
I want to reiterate, it doesn't have to be perfect.
It doesn't have
straight line flow.
Well, the interesting thing here, Dr. Wiley, is we brought this gentleman back. We've looked at his ulcer. It's healing. But what we did was we did duplex studies, and what we're going to do is follow him closely. Now that we have a lumen, we are going to bring him back. Remember, his creatinine was high. We are going to bring him back and do some form of rotational atherectomy to probably reduce the calcium and then be able to do it. But this ulcer is healing. But the most important thing were the techniques that were employed. And I think it was a long case. It was a difficult case. It took us a long time to do it, but we were able to do it. And it's important to understand the importance of the Safari technique in order to provide a rail in order to cross these difficult lesions. For the viewers who watched last month's case, you remember very, very clearly that the laser would not cross and nothing would cross. And you cannot do a rotational atherectomy over any wire. The only question is whether you could have done a Boston Scientific coronary rotablator there, but we were uncomfortable because of the multiple dissection planes that were created from up and over. So always there's different techniques of doing things, but I wanted to demonstrate this very successful result with the subsequent healing of the ulcer. Without further ado, I'm going to go to Dr. Guja, who's going to present the current case while I get dressed, and then I'm going to go over the angiographic review. Dr. Guja?
Thank you, Dr. Krishnan. Can you pull up the slides, please? Good morning, everyone. So today's case, we have a 67-year-old female patient with complaints of lifestyle-limiting claudication in both legs. Left leg symptoms are much more than the right. Left almost has a resting pain, which is a Rutherford Grade I, Category 4. And she's on medication. She has been on medications for about 3 months now, Pletal. And she has been on exercise program, which didn't help her, and she still has resting pain. Her past medical history was significant for hypertension, diabetes type 2, hyperlipidemia. She has PAD known from before. She has CAD, status post PCI of LAD and RCA, hepatitis B, anemia of chronic disease. She's been on Lipitor, metoprolol, hydrochlorothiazide, aspirin, clopidogrel, Lantus, Amlodipine, and Cilostazol, we just spoke about. She's a non-smoker. She has no alcohol, IV drug use. Next slide, please. Next slide, please. Thank you. Her pertinent physical exams, basically on physical exam, is just DP and PT or Doppler bilaterally. Again, there's no tissue loss or no erythema, but she has resting claudication, which makes her a candidate for revascularization. And on imaging, she had an ABI PVR done, which showed dampened PVR waveforms, and left-sided resting ABI was 0.68, and right side was 0.76. We had a peripheral angiogram performed during the PCI when she came in. It showed significant calcified long segment stenosis of the proximal left SFA, a CTO of the mid SFA, one vessel runoff of the left with a peroneal, an occluded AT and PT, significant stenosis of the ostial right SFA with a two-vessel runoff of anterior tibial and peroneal, and an occluded PT on the right. So the plan was to basically intervene on the left SFA, recanalize the CTO, and do atherectomy and PTA. We presenting the case because this is a long segment, calcified SFA stenosis, difficulty, usually have difficulties in managing these kind of cases endovascularly. And Dr. Krishnan is going to go over the details about how it's done.
Kartik, before...
We're going to get right into it. So you can see here by the angiogram, Dr. Wiley, very, very simply, that we did not do an iliac angiogram. Those of you who get my aqua temp already, those of you who watched us know that we always do an iliac angiogram to start. So bottom line here is that we had a iliac angiogram at the time of coronary intervention. We know what the iliac status was, so we know that there was no iliac lesion. It's important for our viewers and the interventionalists who are starting out to go ahead and do that if necessary. Angiographically, you can see here that there's a long diffuse SFA. And now we all talk about lesion length and patency, et cetera, but the question is, how do you manage this without putting a full metal jacket? Then you can see Placine plus Thurby. Then you can see in a second, you can see here, and freeze it when it comes, you can see that you have a short segment lesion. And I think for a live case, to demonstrate the different modalities of crossing the short segment, it may not be a bad idea to show a short segment CTO with the long diffuse SFA. You can see that the above knee pop doesn't have much disease. Next, please. And then you can see below knee, very important to define your anatomy before you start. We say it till we're blue in the face to our fellows. And you can see here that you have a moderately diffuse popliteal, occluded anterior tibial, occluded posterior tibial with a robust peroneal. Keep coming, please.
Prakash, I can't see the image.
You cannot?
I cannot.
Why can't you see the image? I can see it here.
Not on the monitor.
Oh, it's horrible.
Anyhow, this is a claudicant, right? It's not a critical limb.
This is a claudicant, but guys, what's going on with our image? So, no, I don't know, but this we could see it last time.
Can they adjust the wind width and the... there we go.
That's better.
There we go.
Well, that's much better, but he's showing the image here. But now, can you see it now, Dr. Wiley?
Yeah, I see it better, definitely.
All right, well, obviously we're having some AV issues. But you can see here that
It's okay, this works.
at least you can see it now. That's what's important. And you can see here that the posterior tibial runs into the, the peroneal runs into the foot and gives collaterals. So the issue now becomes there's two things. I think the talking points in this case, and the important thing, Mag up please, the important thing in this case is how are you going to manage a calcific SFA CTO, okay, fix the wire. Okay, don't let the wire go. How are you going to manage a calcific SFA CTO, and how are you going to manage long segment SFA disease? So you see what we've done here, Dr. Wiley.
So
we're just taking our catheter here all the way down into the SFA. Okay. Now I told you that she has a high creatinine, so our idea is going to be cross this lesion first. So we talked about in the past in multiple ACC, actually it's before ACC with our own website, about how you're going to cross these lesions and what you're going to do. So we use a catheter here. Why is this so tight, guys? Get me a new Aqua Tempo, please. This Aqua Tempo is not a good Aqua Tempo for whatever reason. It's defective. So what we normally do is we use a catheter called the Aqua Tempo, which is it's a catheter, I won't say the brand name of who makes it, but the point is that it's a catheter that's the directional catheter. And after our ACC live case, what we're going to do, here you go, Sorby. What we're going to do is we're going to go over in a lecture form what are some of the techniques of crossing. Now the important thing is we remember that we did a case a while ago. Hold on, please. That we did a case a while ago where we talked about intraluminal versus subintimal crossing. And I think here, with such a short segment CTO, I think our goal has to be intraluminal crossing. And I think the intraluminal crossing goal will help us because it will help us in the management of this long segment disease. And I've got Dr. Guja to go over some of the data that we have. So there are multiple devices, as you know, to try to cross intraluminal. Obviously, one is the standard wire technique, which you could use here, which is just using an 014 wire over the a support catheter, and then trying to do it. The other is using a rotational catheter called which is made by one of the companies, which basically causes rotation on a diamond tip burr, just sort of on a wire to just kind of poke through, and you can direct it, and that's called the TruePath catheter. The third one is obviously the crosser catheter, which creates micro bubbles and bubbles them up at high speed to go ahead and actually penetrate the cap. The fourth one is the standard wire technique, where you actually use a wire over support catheter and do the similar twirling and the coronary technique to try to find the microchannels to go down. And the fifth one is the Viance catheter, which you're going to mag up now, guys, at the tip of my support catheter to see this catheter in action. Can you go C minus, please? So important with the creatinine being 1.8, we don't want to use a lot of dye. So what we're going to do is we're going to use the fact that we have a measurement tape on the side to see the area of the occlusion. Minus, please. So you can see that the area of the occlusion starts off around, right, that was it. Starts off around 20. So it's right around 20 is where the occlusion starts, maybe 18. Can I have this listening for, please? So it starts off around 18. So you can see we're at 15. So what I'm going to do is I'm just going to gently advance this catheter, right, and let it just kind of find its way down. It's getting stuck in something here, and maybe we're going to need a wire to get down there.
Prakash, I saw you go with a catheter without a wire. Do you feel comfortable with that technique?
Well, it's not a question of feeling comfortable with the technique. I just think, let me see above, guys. Yep. I agree with you. It's not something we normally do. But you can see here now we're in a better situation with the wire and the catheter leading us into the proper zone here. There you go. So we're just going to advance the wire and the catheter down to 20. So
what wire is that?
That is actually a coronary CTO wire, Dr. Wiley, which is made by one of the companies. It's called a Confianza wire, which I think is important. So this Viance catheter is very, very simple. This Viance catheter basically works in the principle. See what happened there? It basically works in the principle of finding the fenestrations. And we know from the coronary technique of crossing CTOs that all these CTOs have some form of fenestration, and that's why we use hydrophilic wires. So basically the whole idea here is, Dr. Guj, just give me a little bit of support here, but not going to push yet. I'm at the cap here, and I'm just kind of rolling this. See what happened there? And as I torque, show my hands, guys. I want you guys to concentrate, please, and show my hands. And as you can see here, what's happening is the catheter is finding the true lumen without me really pushing. And you can see I'm just slowly torquing it, counterclock, clock, counterclock, clock, counterclock, clock. and you can see here it's just going. Now, if you want to really be confident on where you're going, and I think in the early stages of when we're doing interventions such as this, you want to go ahead. Can you set up an IVUS quickly, please? When you want to go ahead and actually see how far away or how close you are, and you can see I've done roadmap to assist me, not that we normally do it, but I think for the purposes of teaching, we can go ahead and do it.
So Prakash, you're attempting to do an intraluminal cross.
Well, the idea here, Dr. Wiley, is I think it reflects, and myself and Dr. Guja spent some time talking about this case. I think two things here. We'd like to, the problem is tackling this long diffuse SFA occlusion, right? So when you have this long diffuse, track the catheter, please. You can see Dr. Guja is going to track the catheter there a little bit, like to give me a little more support. When you're dealing with these long diffuse SFA lesions, you'd like to get away with not stenting these, at least in our practice here at Mount Sinai. I don't think it's, don't push please. I don't think it's necessary to say necessarily that you should not stent these. We do know that stenting long diffuse lesions is associated with a higher rate of restenosis and a risk of stent fracture, which is important. Obviously, there are newer stents like the slotted cell design stents, et cetera, which may reduce the risk of stent fracture, but yet we're still dealing with higher restenosis. So the idea here for us, at least here that we discussed yesterday, would be to do some form of atherectomy. So with atherectomy, we'd like to do an atherectomy of the whole vessel, this including the CTO segment, and hopefully avoid stenting it, or rather spot stent it, which I think makes the most sense. I think two things are in our thought process. I know that myself and Dr. Guja talked about this. One is, obviously, we want to reduce the need for long segment stenting. So we know that shorter stents do better than longer stents. And number two, we'd like to not burn a bridge to future therapies. We're very excited about the future in terms of drug-coated balloons, et cetera, and I think, the non-stent related therapies that are on the way, which are very exciting. We realize that the drug-coated stent is available, and I would be comfortable putting it in this segment if necessary, because the data with the Silva PTX, at least the randomized data, clearly shows in this lesion, which Dr. Guja will go over, it is very favorable. But if we can get away without doing that, I think that's pretty reasonable. So now, just to show you, you saw this fenestrated catheter kind of pop through, and I'm just going to send my wire down, and I want you to see how that wire moves. You see how that wire moves so smoothly? So now Dr. Guja is going to advance the system, and I'm just going to fix the wire so he can get across the lesion, right? Watch this. So Dr. Guja is now across the system, right? Now, since he's across the system, what we're going to do is give me a 7-0 filter, guys. Since our plan is going to atherectomize, what I'm planning on doing here is putting a filter down. Dr. Guja, please track the entire system down. You can see he's just going to track it down. I'm just giving him a rail. Stop, please. Let me just move it down a little bit. Get it a little further. Hold on, let me just get a little further for you. So you can see here that I'm very careful, since it's a CTO wire. I would like to keep it in looped and in my field of vision. Good. So this
are you routinely
are
you routinely putting a filter when you do a CTO, or are you doing it because it's a calcified lesion?
I think this is a great question, Dr. Wiley, and I think we want everybody to think about what are the potential complications and how to avoid them. Now, we do know that here the patient is a claudicant, as Dr. Guja so nicely said. So since the patient is a claudicant, we know that we would like to not make her any worse. So can we potentially make a claudicant worse? Well, we can potentially make a claudicant worse by making the distal runoff worse than what it is when we started. So in our attempt to cross this lesion, we've successfully crossed it. And in our attempt to fix the lesion, if we distally embolize, we need to show them how to do it. If we distally embolize, then the problem becomes that we may shut down the runoff and may convert her into a critical ischemia. From our own personal experience here at Mount Sinai, we know very, very clearly that there are indications that we use, and these aren't published, these aren't accepted, but this is after doing 5,000 to 10,000 cases here, I can tell you that we feel there are certain lesions that are higher risk for embolus. First and foremost, any calcific lesion when you're doing atherectomy, regardless of the modality of device that you're using, and regardless of the runoff, you have to think about using a filter. Number two, any long segment SFA with single vessel runoff, especially when you're doing directional or rotational atherectomy, you should think about using a filter. Number three, any thrombotic lesion, which is a no-brainer. If the wire goes down fast, you know it's thrombus, you should think about using a filter. Number four, any lesion with in-stent restenosis where you have decided to use an off-label use of atherectomy, especially directional atherectomy, you should use a filter. So this is our simple algorithm, and if you look at our algorithm, this patient fits two of the criteria. One, it's a long segment diffuse calcific SFA, which has single vessel runoff, and two, it's a CTO. So I think here is clearly the filter we can use. There are multiple filters available, and obviously there's only one that has an indication for atherectomy in calcific lesions, and that is the spider effects, which is the one we're going to use. Now, in order to save time, everybody talks about how we want to save time. Dr. Guja and I, and actually everybody out there does this a lot, performs a simple step, which is using the crossing catheter here and put the spider effects in. So you'll see what I'll do is I'll stick the spider effects into my crossing catheter and advance it as far as it'll go. If you can show my hands, guys.
Prakash, what would make you use a different filter?
I will tell you in a second, Dr. Wiley. So once the spider effects is in, Dr. Guja is going to push the filter, and once it becomes really smooth, he's going to walk out the introduction device.
Prakash, can you go through the deployment of that filter? That's kind of an interesting way of deploying the filter.
So you can see here, Dr. Wiley, that Dr. Guja is pushing. Is it smooth now? Mm-hmm. And I can walk it out. He's pushing the filter through the crossing catheter. Now what's happened is, as it loosens up, he's going to walk it out, taking care not to bend the wire. That's the key. So see, now he's out. So now he's going to pull this out. And what I'm going to do is just use the deployment catheter to advance the filter. You can see here my deployment catheter is distal. I'm obviously through luminal. You saw the angiogram before. I'm at the level of the popliteal artery. And you can see that the filter will come slowly out right around, let's say, 5 or so. There you can see the filter. There's the wire, right? Now I'm just going to unsheath the filter like that. You see that? So now this is, we chose a 6 or a 7 millimeter filter. Now what we've essentially done here, Dr. Wall, you can see Dr. Guja taking the filter out. He's going to use a hand over hand technique that we taught, which is fixing the right hand and pulling the left hand to the right hand so you don't advance the filter blindly into the tibial vessels. You see here that what we've done is we've been able to place a filter and save a step. Now essentially we're ready to go. We've got the filter down. We've got it ready. Can we get a track back device for the IVUS, please? And so right now we're going to do a quick intravascular ultrasound to see whether we're intraluminal or not, which I think is essential for our teaching.
Now, Prakash, this is your way of deploying this filter, right? This is not
the way it was studied. This is, I mean, I wouldn't say it's an off-label use to do the filter.
But you save us.
But at the same time, I think it's an acceptable alternative use of the filter in peripheral vascular disease. Obviously, space, I'm not going to wait for the trackback device. For some reason, they did not set it up, so I'm just going to use a hand pull back to go ahead and show you the intravascular ultrasound. So I want to do this for teaching purposes, really, to look whether we're luminal or intraluminal, and I do not recommend everybody do IVUS on every peripheral case. I think there are a lot of applications for IVUS in the periphery. Show me above, guys. I think, yeah, around 20 is fine. So you can see here that we want to show what's happening. It's a short segment lesion there. You see the mag up survey, please. So you can see here that the intravascular ultrasound is coming down. It's going to cross the lesion here, and I'm going to go all the way back into the lumen here. So you can see I'm truly in the lumen here. Can we record the IVUS, guys? Okay, so I'm just going to slow my Prakash Krishnan 1 millimeter pull back. Hold on, Ricky, it's too late now. So you can see I'm just doing a pull back. Can you put on ChromaFlow? Please.
Oh, you could clearly see you're intraluminal.
Well, I just want to make sure that everybody sees it with flow. You got it? Huh? No ChromaFlow? You got ChromaFlow? It's on. I don't see it. Is there ChromaFlow or no, guys?
Yeah, we'll get.
Okay, just want to make sure there's no technical issues because I want to stay on time. I see, no problem. So now there's ChromaFlow. So we're going to go with ChromaFlow and in the pullback, and I want to see whether we get any flow as we get to the lumen. And you can see here there's still flow, right? And now we're probably getting into the occluded segment. Now you can see how the layers are so clean. You see how we're truly intraluminal here, guys. You can see we're intraluminal. You can see the adventitia, the media, a little less clear here, maybe slightly subintimal, but I doubt it. And you can see here we're just completely occlusive within the lesion. And you can see that the structural integrity of the vessel wall is clearly seen. And you can see here proximally we're out.
It looks interluminal to me.
I just wanted to show you that, Dr. Wiley. So now that we're intraluminal, so now we know that, we did a true intraluminal cross. Now, as we know, and as you know very well, we've looked at the data a few times, there's really no clear data, but I think it's very exciting, especially in terms of the future of drug-coated therapy, et cetera, whether this is going to make a difference. Now we're going to do a LSM catheter, which is a catheter for directional atherectomy. Now, the reason we're doing a directional atherectomy catheter, and I think here we can do multiple different things. We can do an LSM catheter, we can do a rotational atherectomy with the Jetstream catheter, or we can do a simple plain old balloon angioplasty and stenting. I think when drug-coated balloons are available, that may be the mainstay of therapy. Remains to be seen in such long lesion subsets. But I think in today's day and age, the real practical approach to these lesions is how can we get an effective result in this lesion. I think today's options are very, very simple. FDA-approved options are obviously stenting, which there are multiple stents that are on label for SFA use, and there are also multiple stents and balloons, and obviously now you can also have directional atherectomy. So directional atherectomy has been studied, and as we go over this, I'm just going to have Dr. Guja in a second present some of the data that's available. But at this stage right now, I want to show the technique of directional atherectomy, okay, in a chronic total occlusion. So I'm going to have Dr. Surabhi press roadmap for me, and then I'm going to ask her, she's going to give me a little bit of dye, right? Now inject. So what we do is for teaching purposes, we're going to give roadmap, okay? So now Dr. Guja has prepped the device, and I just want to talk about how we're going to cut this lesion to try to get the plaque out. So right now we're going to go in. It's an 014 system, which is sort of a monorail type system, and I know most peripheral interventionalists are doing some form of atherectomy in their practice, so it's not novel, but clearly I think the techniques are evolving. We do know that this device has certain advantages and certain disadvantages. The advantages of this device are very, very simple. I think first and foremost, it gives you a large lumen because you're able to get at least a 5 to 6 millimeter lumen out of this device. Second is you're able to direct it away from areas that you're concerned with. Say you have I don't know, sort of a gutter or a perforation, not a perforation, an area where you don't want to cut for whatever reason, I don't know, away from a stent strut or a calcific area, you're able to direct it. Or say you have plaque that's, I'm having trouble advancing it off roadmap, please. Or you have plaque that's eccentric and you want to direct it towards it. So you can see here that this is not going to go here, even though we're trying to get this down. So here we're not going to be able to advance the directional atherectomy as we thought, which I'm actually quite surprised with. There is a little bit of a tight lesion here. So what we're going to have to do is do a short balloon. So give me a 30100 balloon, guys. And let's take a little picture here, please. This is very surprising to me because normally this will go without a problem. That's it. So it's probably an edge of calcium right there. You know, it's getting stuck around probably 100, I mean around 12, huh? What do you think, Dr. Wiley here? I'm very surprised that this is getting stuck.
Yeah, I think you have a couple options, as you said, going with a small balloon. You could laser with a 0.9 catheter.
You can use a rotational device here with the pathway.
Correct. So you still have several options in your tool case.
Right. So what I'm doing here is I'm severely undersizing my balloon. The reason I'm severely undersizing my balloon is so hopefully that I don't cause any dissections here. So we know that the average SFA is from anywhere from 5 to 6 millimeters, or 5 to 7, I should say. And so we're going with a 3.0 balloon here. I think the whole idea here is to create a channel without dissecting to be able to get this device through. I'm very surprised, honestly, that it did not go through. So what we're going to do here is just fix this very quickly with a balloon, and this is exactly what we're going to do. Rail, don't pull the wire, please. Thank you. Rail, please. Mm-hmm. Now, you can see where the wire buckles means your filter is moving. So it's important for Dr. Guja to hold that steady, and now he's doing a great job. Okay. So we're just going to go across. Okay, we're going to go across the lesion. Okay, now we're just going to balloon this segment. Let me make sure I'm not ballooning my CTO. I'm not. So we're just going to go with a quick nominal balloon and see how it expands to see what the reason for this issue was. Huh? Slow. So you can see here that the much tighter eccentric calcific lesions in 2 spots. So we're just going to go ahead and just open those up slightly. And you can see that's the reason why the Silverhawk did not cross. And you can see here, Dr. Wiley, there he goes. He just gently easing it open. And you can see his pressure is right now around 5. And I'm going to tell him to take it to 6 and maybe 7. And you can see it's starting to ease up here. And you can see still proximally there's a tight shelf of calcium there that should be enough for the Silverhawk to cross.
Prakash, so when we go ahead and do a balloon angioplasty of that segment, we open a new set of worms based on the fact that perhaps you may cause several planes of dissection. The question is whether you go ahead and do atherectomy or what?
Well, I think that's a great question. I think we undersize the balloon here so that does not occur. So now here, clearly it's a 3-0 balloon, but you can see it's quite a tight lumen. So we might have, walk this out please. So we might have caused a dissection, but I think here there's no other options here rather than the other option obviously is just balloon angioplasty and stent. Our idea is not to balloon angioplasty and stent here because of the things I outlined earlier. So therefore, in order, we're limited by the availability of our devices. Well, some may say, hey, why not do a rotational atherectomy here? I don't think that's a bad idea. I think you can do it. But the fact that we opened the Silverhawk atherectomy, the fact that a 4 French, catheter or diagnostic catheter went through that, I had no reason to believe that the Silverhawk would not.
How high did he go in your balloon?
With 6 atmospheres.
Oh.
So nominal is 10 or 8. And we only went to, I think, 5 or 6 atmospheres. So, so nominal is 10, I was just told. So now we're going to try again. And, listen, this is part of, peripheral intervention. And it's unfortunate that, in the coronaries, you have certain things that, you try. Like, we go ahead and do a 1.5 balloon. If the 1.5 balloon does not cross, then we know we have to go with a 1.25 burr, things like that in coronary rotational atherectomy. And I think when peripheral atherectomy, I think certain things also occurred. There are no hard and fast rules. Show me above, Serby. But clearly, you can see that in this particular lesion, we had this issue. You can just show me a 20. If it doesn't cross, I'll tell you. Actually, let's just leave it there. Let's see. So I'm not going to go on roadmap again because of dye issues. So I'm just going to try to see how this passes. I would be very surprised if it doesn't pass. And if it doesn't pass, we might have to rethink our strategy here. But I would be extremely surprised, as I told you. And here it goes, like we talked about. So now here we're at the lesion here. So when at the lesion, I want everyone to push it through the lesion just as I did there. The reason you want to push it through the lesion, show me above, Serby, please, and don't pan. The reason I want to push it through the lesion is I want to make sure that the cutter is open and the cutter can smoothly move. So you can see here, how we're going to cut this is a 4-quadrant cut. So when we come down, we know the lesion started around 20, so I'm going to start at 19. Now I want you guys to mag up, please, for me. That's good. So now you see the open face, Dr. Wiley, the open cutter head. Now that open cutter head is facing towards the femur bone. So this is a lateral quadrant cut. So I know that it's around from 19 to 26. So I'm going to do a lateral quadrant cut here on. Very, very slowly, nice and smooth. You can see here that I'm trying to move it extremely slow. And I know a lot of people have trepidation about doing chronic total occlusion Silverhawk. Show me a little lower, Serby. So you can see here, I'm just going to try to take it in that lateral quadrant all the way to 26. Off. So you can see here that the plunger went ahead, okay, and now I'm still facing lateral. Now the important thing is show our hands, please. So what we're going to do is we're going to twist here in a clockwise direction till the cutter head faces either anterior, which is, you can see the cutter is either facing toward me or is actually against me. You can't tell in this 2-dimensional view. So now I'd like to advance in this quadrant. On, please. The problem with this device is it tends to rotate back into the other quadrant. So you have to pinch it. You see what I'm doing with my fingers to actually pinch the device, prevent it from rotating back. And I'm still cutting in this anterior quadrant.
How can you
off.
tell if you're anterior or posterior?
Well, anterior or posterior, we don't know.
Okay.
So now you see how this rotated all the way to the lateral quadrant? Now, if I'm a purist, I rotate this all the way back to medial, or to lateral, and then clock it again till it comes to medial. So this way I know I'm not guttering. On again. Now you also saw that the plunger is getting full, or the head is getting full. The collection zone, which is front, for lack of a better word, nose cone. Off, please. So now I'm going to actually see how full it is. I'm going to go a little slower. On, please. Try to finish this cut. I might have to make one more cut because I'm collecting a lot of plaque here. Off, please. So I am definitely full. Now the key is Dr. Guja is going to put pressure on the finger here to prevent it from spilling, and then I'm going to pull it out as a system, knowing that he has pressure. And I'm going to monorail walk this out so that you can see what's happening, and then we'll empty this and show you what we collected. So Dr. Surabi will now take an angiogram as Dr. Guja gets ready to empty it, and you can see what's going to come out of it in a second. Ready, Surabi? Okay. Good. So you can see with a 4-quadrant cut here, you've got a little bit of a dissection, which I think is not a non-flow limiting dissection, and we've got a nice central luminal appearance of this particular cut that we've done. Obviously, we have one area, guys. You can't show that, guys. You cannot. They cannot see anything. I mean, that has to be fixed. Please show over here. So please show the live image, guys, not the image on the screen over there. I mean, thank you. So you can see here that with the cut, and even during fluoro, please do not show this. Jose, were you able to see our cuts on fluoro? No?
Yes, now I do.
Well, now you do, but before you couldn't, right?
Well, we saw the cuts, but we didn't see the results.
Well, okay, now you do. Well, you need to let us know what you can and cannot see. So you can see you have a little bit of a section there, Dr. Wiley. And now the question becomes is what we can do. In the meantime, I'm going to run another IVUS quickly through.
You know, Prakash, it's not a flow limiting dissection as you
No, I
pointed
understand.
out.
I'm just going to run an
It's
IVUS
quite
through to show you
short.
what this looks like. And again, I don't implore anybody to do IVUS as what we're doing here. We're doing it for teaching purposes, and I don't think there's an indication for IVUS at this stage right now. But I think it's important for those starting, at least in this format that the ACC has kindly given us, is to really show that what's happening to the vessel and what we're doing, so that people who do this on the outside don't have to do the IVUS.
So, Prakash, what difference would it have made if you used a balloon angioplasty and that's it?
Well, you know, you're right, Dr. Wiley. Balloon angioplasty is fine. I don't think it's abnormal. We do have data showing that stenting is better than balloon angioplasty in the New England Journal article. We have registry data with definitive LE. That definitive LE shows something. And you can see some of the plaque that we took out. Dr. Guja is just showing some of the strands of plaque. I mean, it's not an awful lot, but clearly we're able to get out. You can see this thrombus associated with it. So now I'm starting distal, and you can see with the intravascular ultrasound, and I'm just going to go to 26. And I'm just going to pull it back very gently. And I can show you, even though we have a good luminogram, okay, you can see here, there's our dissection that we talked about, right there. You can see that nicely. And you can see you still have a pretty good amount of plaque left. But I think overall, I mean, there's a lot of plaque there, and that's probably the posterior wall where we're at. We're actually not even through it. Now we're in the lesion. There we go. So there we go. So we actually did a pretty good job of cutting there, Dr. Wiley. You can see there, we still have some eccentric plaque. There's some eccentric plaque there, and we are out. So I'm probably going to do one more quadrant cut here, which is the posterior quadrant, and I'll show you how I'm going to do that after you've removed the device, which is very important so you don't cut the same plane. You can see that we don't have any horrible dissections anywhere, okay, which is good. And so I don't think there's anything that necessitates us to stent. So I think now we're going to go forward with this. And then I'm going to go ahead and do some runs totally. So here we go. So we're going to go back again. And the part of the disadvantage of this device, I guess, is the cleaning. They have improved the nose cone for us to be able to add more space for us to obviously pack more plaque. But obviously, you know, we did have to pull it out because of the heavy plaque burden of this particular area. So now we're going to go ahead. And I'm just going to go ahead and do the posterior quadrant cut. So you can see here, Dr. Wiley, as I come down. I am going to ask Dr. Guja to do this part, which is very simple, which is we're going to start medially again. Actually, I'll just do it for time's sake. So we're going to start medially again. You can see that there's medial at 19, right? So let's start medially. So what we're going to do is now clock it. So this is anterior, posterior. This is lateral. And now this is, again, anterior or posterior, okay? So now at this stage, I'm going to move it back and forth. See how the tension was built up and it moved again? So now I'm just going to adjust it a little bit, okay, to make it anterior or posterior, get the tension out of the catheter. On, please. And now I'm going to go down straight.
You just mentioned that there's randomized controlled data in stenting. Why not stent it?
Why not what?
Why not stent?
I agree with you. I don't think it's wrong to stent. Come down below, guys. I'm not saying at all that it's wrong to stent. I do not feel this is an interesting case because it is a long segment it's a long segment SFA stenosis. And I think long segment SFA stenosis with stents has its limitations because of fracture and high restenosis. We know that stenting is better than balloon angioplasty in the New England Journal article. We know that. However, in this particular area with the new technologies that are coming, it may not be what I want to do. Show me down below, guys. Okay. So now I want to take a picture of the filter to see whether the filters pull. And I think this is a good habit that I want everybody to get into, is to mag up and take a picture of the filter, please. And we're on coronary, right?
Yeah.
So we're going to just take a picture of the filter to see whether we could capture it. Inject. That's enough. Don't inject the whole thing. So you can see the filter has nothing in it at this stage, which is good. So now we're going to go forward above, and we're going to do atherectomy proximally. Clean that out quickly, guys. Low mag here, Karthik.
Yeah.
That's good. Okay. So now we're just going to do medial cuts, lateral cuts, and long segment atherectomy here, Dr. Wiley.
Okay.
Can you please get me that catheter quickly, please?
So, Prakash, run us on your algorithm. If you had plaque or thrombus or something in that filter, how would you retrieve it? Would you put another wire and put a suction catheter? What would be your approach?
I think that's a good example. I think Dr. Wiley is talking about when a filter gets overwhelmed. What are the things that we normally do? Well, if you have embolic debris onto a filter, what you want to do at that stage is to go ahead and not to capture that filter, because the filter may actually spill. So a lot of times what you see when you take that picture, you actually see debris within the filter and actually proximal to the filter. When you see debris within the filter and actually proximal to the filter, what you see at that time is actually that what you need to do is go down with a multi-purpose guide, okay, with one of these coronary aspiration catheters like the Pronto. So these catheters come with syringes. Don't think that aspirating with coronary thrombectomy catheters are going to be enough in these cases. So what we do is we take a multi-purpose guide, put another wire, not the same wire as the filter, into the filter. At that stage, what we then do is take the multi-purpose guide down, okay, into the filter, and then turn on the Pronto catheter. When we turn on that, not the catheter, the syringe.
The syringe.
As we turn on the syringe, mag up now, guys. As we turn on the syringe, we go ahead and suck out, with the back and forth motion, we suck out the clot. So now again, I'm going to start medially. Okay, on please. So, and then we suck it out. So that's the way you manage that. So when you do long segment SFA, what you want to do is really advance the catheter nice and slow, okay, and do packing when you reach the length of the nose cone. Pack, please. Okay. See now you see how the catheter jerked back. So we're going to go back to the medial plane, okay, which is right there. On, please. And what you want to do with the frequent packing is that it prevents you from actually overwhelming the nose cone. Off, please. Now people may say on, please. Yep, clock it back. Clock it back to the other, good. On, please. So you can see that the frequent packing is a good technique to do to prevent distal embolization. So we're going very, very smooth. We know we have to get to 20. On, please. You can see how difficult this catheter can be to handle. As you see, Dr. Guja is struggling to keep it on plane. And I'm just going to go all the way to 20 or 19, not to cut past. Off. So we made one full pass there, and I'm going to come back up top. And what you can do here,
It looks like you almost packed the nose cone again.
almost, again, we're going to go medial again. We're going to start medially again. Dr. Guja is going to go back medially, and now going to clock, and that's fine. And you know, you cannot spin this too fast. When you spin this too fast, you'll spin it around the wire, and I think a lot of inexperienced operators do that. So what you want to do is you want to go ahead and start it medially, okay? And then what you want to do is get the tension out of the catheter. Okay, now you know you want to go anterior posterior, so you're just going to clock it gently. See, as you clock it gently, it'll move anterior posterior. See, had so much tension on it, it's got to go all the way around. You see that? And that's what happens. Dr. Guja was spinning it a little bit fast, and because of that, the catheter tends to jump. Survey mag up for me. Let me do it, Karthik, please. So you can see you want to go very, very smooth. Straight system. Okay, and now you're anterior. On, please. On. And then you want to just come down smooth. Off. This is one of the problems here, Dr. Wiley, as you see.
Yeah, it jumped.
What's happening? On. And I think long segment lesions pose the most difficulty in guttering. Off. On.
It's full.
Yeah, it's getting full. Dr. Guja is telling me it's full, and I agree with him. Off. Okay, let's get the other one. So we stopped around 11 there.
So Prakash, would you tackle that dissection with a prolonged balloon inflation, or you leave it as it is?
I want to take a look. I mean, definitive LE clearly showed, the registry data showed that ballooning was actually worse. It didn't make a difference. So what we're going to do here is just probably take a look and then decide as a group what we're going to do. So as long as we get a better lumen than we started, which we already have done, I think this is the best thing. Now remember I said we stopped at 12, right? So I'm going to start a little bit above that in the same plane and then go forward. So as I keep cutting, now I'm going to cut away to Dr. Guja, and Dr. Guja is going to present the data and go over the slide presentation. Karthik, do you want to scrub out for a second and just do that? Or and just do that? Can you just put it up there and focus on Karthik?
Can you put the slides on, please?
Come, forget that. Come, hold this.
So I thought it would be a good idea to start off with class classification. So this particular case, as we just saw, it comes as a type C lesion. Let me just go over it quickly. Type A lesion is anything, a single stenosis less than 10 centimeters, and an occlusion less than 5 centimeters. Type B lesions are multiple lesions or stenosis or occlusions, each less than 5 centimeters. Or a single lesion or stenosis less than 15 centimeters, not involving the popliteal. Once it involves the popliteal, it becomes a type D lesion. Type C lesions, again, are multiple stenosis or occlusions, like in our case, totaling more than 150 centimeters. As we clearly saw, we took a 150 millimeter balloon, a 3O balloon to predilate initially, and still it was falling short of the whole lesion. Again, recurrent stenosis or occlusions that need treatment after 2 endovascular interventions fall into type C lesions. So this is a type C lesion, again, calcified long segment SFA. Next slide, please. So Zilver PTX trial by itself, randomized control trial, took less long segment lesions, but the registry data has good data on long segment lesions. So they again included complex SFA lesions in the registry data, nearly all corners. They took Rutherford category 2 or greater, as our patient is. Lesion length was limitation. Up to 4 DS were used per patient, and the longest stent length was 8 centimeters. Multiple lesions per leg were used. Stenosis more than 50. Again, occlusions, restenosis, in-stent, everything was included basically. A follow-up was for 24 months. Again, current data available is again 12-month follow-up and 24-month follow-up in about 177 patients. Next slide, please. So the freedom from TLR in the registry data, again, for 12 months and 24 months, you can see specifically I picked up TAS C and D lesions because it's pertinent to this case. For 12 months, it's 86%, and for 24 months, again, it's 75%, pretty good for a drug-eluting stent. Again, they looked at the lesion lengths. You can see on the third para, it's less than 7 centimeters is 94% and 91%. More than 7, but less than 14, it's 89 and 72%. Again, more than 14 is 77 and 73%. As all you guys know, traditionally, 70 millimeters or 7 centimeters has been an average length stent for most of the studies. And more than 15 is again considered a long segment lesion. Again, occlusions and stenosis were included in it, and you have the percentages right there. Next slide, please. I thought it would be a good idea to go over the literature and look at all stents which are available in the market, the bare metal stents versus and match to the registry subset of the ZillowPDX, which is a regulating stent. Again, the first resilient trial which looked at the live stent. Again, we look at the lesion lengths are less than 15 centimeters. Again, when compared to ZillowPDX, which is more than 15. Again, you're talking about patency rates of about, again, restenosis rates less than 13% here, 15% here. This is the TLR rates. Again, so that means you have pretty good patency rate right there, which is 95% almost in ZillowPDX. Again, looking at the fast trial, Luminex stent, again, pretty much similar results. As I said before, most of the bare metal stents have included lesion length less than 14, which again doesn't classify them into task C lesions. They're all more task B lesions. Again, durability, same thing with the Prodigy Everflex stent. You can go with the next slide, please. And looking at another 24-month data and compared to Resilient trial 24-month data, again, when compared to ZillowPDX, it's about 88% TLR rates when compared to 20% in the bare metal stents, which is pretty good. Again, as I'm going to stress it again, these are all task A and B lesions in Resilient trial, and your ZillowPDX again is more than 15 centimeters, which is, and Rutherford more than 3. So you're talking about patients who are pretty resistant to any kind of a treatment right here. Next slide, please. So I thought this is a ZillowPDX trial, a randomized controlled trial data. Again, the last information which is there in this trial is the lesion length of more than 7 centimeters, which is pertinent to our case. Again, clearly shows that the DES is better than plain old balloon angioplasty. Again, the next slide, please.
Registry data, correct?
Next slide, please. Thank you. So I thought it would be a good idea to go over definitive LE, which is atherectomy data. This is not a randomized control. This is more of a registry data. But again, like in our case, we looked at the lesion lengths of task C lesions, which is looking at here the lesion length 16.5 centimeters, which is probably the same as our patient here right here. And the patency rates are 72% when compared to plain old balloon angioplasty. Can the next one, please? This is a slide showing definitive LE atherectomy versus all the PTAs and the bare metal stents. Clearly, the ZillowPDX drug-eluting stent trial has shown a little better data, and there has been no comparison. This is just a matching bar diagram. Next. Again, the primary patency, you can look for more than 10 centimeters. That is mean length of 14.4 meters is 67%. Next, and the number of lesions were 2 to 14. Looking at where the atherectomy was done, SFA here clearly shows that the mean length is 8.1, it's 75%, and clearly more in infrapopliteal lesions. Next.
So this is some of the atherectomy tools that are available, and Karthik is going to go over each one of these. This is atherectomy with aspiration. If you can play the video, this is the Jetstream device.
This is the Jetstream device by, again, looking at, this is more like a rotational atherectomy, you can say, but this has both atherectomy and aspiration thrombectomy. This device is very good in calcified lesions and lesions with significant stenosis. If you suspect that there is thrombus there in those lesions, then this is a good device because you're not sending any thrombus downstream, and you're doing aspiration at the same time as atherectomy. Next slide, please. This is again a rotational orbital atherectomy device, play on. And you can clearly see it. We initially started at lower RPMs and then go over, just like in coronaries, pretty much the same modality. Again here, the particulate matter is less than 10 microns. So if you use a filter, you can pretty much get everything which is going downstream. Okay, next slide. This is a directional atherectomy, which we are using right now here, which is a Silverhawk system. Again, you have to pass the nose cone through the lesion, and then you start right at where the lesion is. You open up the cutter, and you give a directional cutting. You do one direction cutting, as you're seeing right here. And once the cut is made, you have to close the nose, close the cutter, pull the nose cone close the nose cone, pack it, and then pull the device back, redirect it, and go in a deeper cut. You have to go very slowly, as Dr. Christian was showing us here, to get a deeper cut. You can clearly see once you go a little more slower and a deeper cut, change the direction, you can clearly see you get a deeper cut there. Okay, next slide, please. Again, this is laser excision atherectomy. We wanted to go over all kinds of atherectomy systems available in the market. So in laser atherectomy system, this is clearly a very short CTO. We basically place the wire, make sure you take a J-tip wire or make a loop in the wire, go against the lesion, then you bring your laser very close to the lesion, and then you start your laser. Your laser, by the help of, it's been shown, I mean, just like in coronaries, the same main peripherals, you create a particular matter which creates a lumen right there with the laser heat generation, and you can see there it's drilling through the lesion.
Kartik, it vaporizes the tissue, correct?
Yes,
With
it vaporizes the tissue. Basically, heat generation, changing the tissue into particulate matter, and the particulate matter is just pushed away.
Laser, it's a cold laser.
That's right. It's a cold laser.
It's not a cold laser. So again, the point is laser is one of the options. Go next, please. And now I want to talk a little bit about the crossing of CTOs. You saw a luminal device that actually enters into the lumen. Here's a lumen reentry device. Now, say you guys are subintimal when you get to the lumen. There's an FDA-approved device for luminal reentry called the Outback device. Next, play it, please. So you can see this is the up and over sheath, and here comes now you're subintimal. The device comes in, which is called the Outback, and then what you have to do is basically torque the device to face the lumen by using different techniques, by looking angulation with the camera as you see towards the left of the screen. So you go 30 degrees, you go basically 60 degrees opposite, 30 degrees to the contralateral RAO, LAO, find the lumen, L&T configuration, and then you're going to go ahead and fire the needle. So when you fire the needle, the needle will break the subintimal space, okay, and enter the true lumen right there. So once the needle enters the true lumen, which we did not have to demonstrate, although we had this device here, you can go ahead and advance the wire through. I think if you're doing chronic total occlusions, this becomes an essential part of your armamentarium, because as good as you are, you're going to have difficulty getting through all chronic total occlusions.
So you do a 90-degree angulation to see a T and an L.
Yep, contralateral. Actually 180, Jose, is what they say. So you can see here, Jose, just to come back to live flora here, we're done with our presentation briefly. Thank you, Dr. Guja, is to show what we did. So let me show you here. We did the angiogram post, just atherectomy. We did, Dr. Serby and myself did atherectomy throughout. And you can see here the first shot of the proximal. You can see by the glow tape where we are. Very, very nice looking lumen, good flow. Next, please. You can see the chronic total occlusion segmented area. Very, very nice flow right around where the filter is. Plus, please, I'm so sorry. Next, please. You can see very, very nice flow around the filter, and you can see the filter has something. Plus, please. And then when we look again here, and then the high mag, you'll see that the filter has some goober in it. So what we're going to do is capture the filter now. So I just want to show you in the high mag. I'm taking the filter retrieval device. It's not overwhelmed, Dr. Wiley, so we can't capture the filter. I'm sorry, I kind of jammed that in there. I didn't realize I was that close. And then what you want to do is pull the filter back into the basket. And notice I'm not doing a full retrieval. I'm doing a partial retrieval here because of the goober, and I think that's extremely important. So now we're going to pull the filter out, and Dr. Guja is going to examine it. And what we also do is very, very simple. Show me here, please. What we also do is bleed back in case anything is stuck in the sheet, and then flush this forward, please. Flush. We also flush the port to make sure that there's nothing stuck. So once there's nothing stuck, we then will now go low mag here. 48, please. And then we're going to take a nice distal runoff. Widen my shields, please.
Prakash, can you comment on the fact that most of the devices that you very nicely showed on the presentation does not have randomized control data, and is randomized data that is being presented? Can you comment on that?
Yeah, I think honestly that you're right. I think that needs to be done, but I think there's a little bit of so there you go. That's fine. So you can see there's good flow. But you know, Jose, I don't want you to knock the definitive LE data too much. I know it's not randomized control data, but let me tell you, it's multi-center, it's core lab adjudicated by both angiographic and ultrasound core labs. So clearly, it's not as powerful as randomized control data, but I think it's definitely respectable data that we can look at. Can we apply it to all lesion subsets like we to do in practice? I agree with you. I don't think there is data to say that, but also we know in clinical medicine it's pretty impossible to know every lesion subset to say, hey, we have data to say how to treat every single thing. I think part of it is the growth phase, and a part of it is the understanding of where we're going. Our logical approach to this particular patient, and I don't mean by any means to say that this is the only way to do this lesion. I think you could balloon angioplasty it. I think you could stent it. I think you can bypass it. I think you can leave it alone. I think it just depends on what your approach is and what your philosophy is. Our philosophy here is very, very simple here at Mount Sinai. Our philosophy is that we know that long stents tend to restenose more frequently and tend to fracture more frequently. We know we have data with long segment SFA lesions at the current time with atherectomy, with especially directional atherectomy. So we know that there are future therapies on board that are coming on, which again may improve our patencies and thereby improve our patients' lifestyle. So based on that logic, whether I'm right or wrong, and I think it's open to debate, and I would love to hear comments from our audience on that on our blog, but clearly I think that this is an effective manner of treating a claudication. We'd handle the CTO without distal embolization, without perforation, without complications. We handle a long segment SFA without having to place a stent, without significant dissection, and without any complications. Yes, we know that this is a greater than 150 millimeter lesion, likely to be 250 millimeter lesion, that is not studied in any subset that I'm aware of at this stage. So therefore, what are we doing? We're doing the best application of our therapy at this stage to this particular patient. My hope is that in the future we will have some form of drug therapy or some sort of plaque modification therapy, whatever it may be, that is going to help us to treat these patients and give them a more prolonged patency would be my hope, Dr. Wiley. So it's a very difficult thing.
I agree with you, Prakash. I think it's important to understand the limitations of our registries versus randomized controlled data, particularly because the degree of association between intervention and outcome is poor just based on this experimental design. Fortunately, we cannot control for confoundings and biases, but that's all we have available at this time.
Right, and I think here we've done a reasonable job. I have not ballooned it. Now we're going to make that decision offline. I don't know whether we're going to balloon it or not. You can see there's great flow to the foot. She's a claudicant, so we know that we want to improve flow into the sural branch of the popliteal artery. So hopefully at this stage that we've done enough to help her. What we'll do is we'll go back and what we normally do here, Dr. Wiley, is we'll run a gradient across the SFA from distal to proximal, because a lot of times we find that resting gradients of 10 or 20 or even 15 exist. So usually if it's above 10 as a resting gradient, we have no support this, we'll put out a prolonged balloon, undersize our balloon to prevent dissection and try to eliminate that gradient. As you know, if you have a resting gradient that's high, then obviously that may become more significant upon activity of the patient.
Prakash, the other comment I'd like to make, and I don't know if you agree, core lab adjudication and a registry not necessarily makes the trial better, it just makes it more expensive. By any means does not make a registry a randomized controlled study.
No, I don't think anybody's saying that makes it a randomized controlled study, and I think study design can be discussed without a question in multiple different ways. I think there's a lot to say about independent core lab adjudication, because obviously it provides validity to the trial, it provides validity, you need an 035 wire, provides validity, go ahead, do a gradient, provides validity to the fact that this has been independently adjudicated in terms of the angiographic stenosis as well as the ultrasound restenosis. So I think it adds a lot of value, Dr. Wiley, and I know you're a purist, but at the same time, I think that you have to take things for what they are. I agree with you. It is not a randomized controlled trial, nor does it make it a randomized controlled trial, but clearly, it does help and make the trial a little bit more powerful. But I think the key points that Dr. Guja made are very, very simple. I think very, very exciting drug-coated therapy, especially in form of Zilver PTX. The problem there is the randomized trial studied stents of only 80 millimeters in length. So therefore, it limits their use here. However, in this type of lesion, if we had a flow-limiting dissection, we have Zilver PTX, we would have put that particular stent in this particular patient. Number two, in this type of long segment lesions, I think, again, very clearly, crossing the CTO we talked about the technique that we used, and it was very, very clear, which I'll go over in our overview.
Prakash, I have to commend you. This was a complex case that you made it look very simple.
Well, I think our point here, Dr. Wiley, was to show the audience that, how can you tackle, there's a real world case, it's not the most difficult case in terms of people out there can easily do this, but I think it's important to open the dialogue and how different people handle this. And I think crossing the CTO is nice, it was a nice way we crossed it, and I think it also shows you exactly how you can handle the long segment lesions. So again, I open your comments on the blog, please comment to us. We learn from you as much as you learn from us. Again, I thank Dr. Guja for doing such a wonderful presentation, Dr. Serby for being such a great assistant, and obviously Marichu and Ricardo for helping us, and yourself as well, Dr. Wiley. Thank you again. To the audience, we will be back. We're not going to be back on the day before Christmas. I believe the next one will be December 18th. So please mark your date on December 18th because obviously the holidays are there, and we're not going to work on the 24th, nor do we expect you watching us at Christmas Day. So with further ado, I'm going to sign off from here in the Cath Lab. I will be presenting a lecture in a few minutes, so please log on and see the lecture. And again, I thank you very much, Dr. Wiley.
Prakash, great job. Once again, we'll see the audience back on December 18th. That's the new date for our next live webcast. Thank you very much.